guidelines, the 2025 KDIGO guidelines. One is biopsy the patients early. If you don't have a specific diagnosis and somebody has 0.5 grams of proteinuria or more, then you should be doing a biopsy. If you have a diabetic and you know they have a diagnosis already, or if you have somebody who has a genetic disease and you know they have a diagnosis, it's not necessary. But the ones that are unknown, you should consider a biopsy in those people because, again, they could have IgA nephropathy and you can do something about it. Now, what are our goals now? The goals have changed. So looking at now, we're trying to get the protein-creatinine ratio in the urine down to less than 0.5, and if possible, less than 0.3, which is a very low amount of proteinuria. It's not always possible, but that's your goal of therapy. And your long-term goal is to keep the loss of kidney function down to less than 1 cc per minute per year. So those are changes as well. A third big change is looking at the pathogenesis of IgA nephropathy, focusing on non-specific factors that can influence the course. That is, looking at the glomerulus in terms of ACE inhibitors and ARBs, SGLT2 inhibitors, endothelin antagonists, and those that change the glomerular inflammation and the production of galactose-deficient IgA1 and the immune complexes. So medicines such as Tarpeyo, we know acts on the distal ileum and the Peyer's patches there, and it prevents the production of galactose-deficient IgA1 and the immune complexes, and also goes back and prevents the proteinuria in the kidney. Some of the other agents that are now being developed also block the production of the galactose-deficient IgA1 and the immune complexes, and also reduce proteinuria. And some act mostly on, the newer agents act mostly on the reduction of proteinuria and inflammation. So we have many places now that we can act on changing what the course is of the disease, and KDIGO focuses on that. KDIGO Guidelines 2025 talks about simultaneously or at close to the same time acting on several different areas. We know we can reduce proteinuria by using an ACE inhibitor or an ARB, or an endothelin antagonist, or an SGLT2 inhibitor. But is that the same thing as blocking the production of galactose-deficient IgA1 and the immune complexes? And most people think not, because one is changing the pathogenesis, the other is changing the effects of the pathogenesis. So the guidelines now recommend acting at both places at the same time, and that's a big change from what we've done in the past. Well, it should be combining strategies to treat both parts of the paradigm here. So when we look at this, we want to do our maximum things to decrease the proteinuria, non-specifically decrease glomerular hypertension, decrease proliferation in the glomerulus. At the same time, we want to turn off the process that led to this, that also will decrease proteinuria. And that's more mechanistically important. These drugs are very widely used. I use them all the time. I like sparsentan because it combines the efficacy of an ARB and endothelin antagonist, and it's a single pill, a single drug. And that's very good because, again, we're talking about using multiple medications in these patients. I like targeted release budesonide because it gives me the efficacy of steroids, but it's much less on side effects. It's really for the reduction in side effects that's a major thing. So you may get some people with a little bit of hypertension and edema, or somebody may have, mild acne with this, but that's very different than developing diabetes or infections that are the big worries with steroids, especially if you use higher doses. Well, there are a number of difficulties for the clinician. One is getting insurance approval, that there's often a delay in terms of this. And again, having a drug that is FDA approved and has its final approval, it's hard for insurance companies not to agree that this should be used in this disease. I mean, it's FDA approved for that reason. Now, If they have preliminary approval, they can always argue that there isn't endpoint data. So that's a difference in terms of this. So the other thing is using multiple medications. You have to talk to the patient and say, look, we're going to use several medicines at the same time. I know you're going to be starting a bunch of drugs, but it's important to prevent you from developing dialysis or need for transplantation. And, we think all the time that nobody, if they had a malignancy, would worry about the oncologist saying, take these 4 medicines, it's got the best survival rate. Well, it's the same thing. If you need multiple medications, we should be able to emphasize this combination is going to prevent you from going to dialysis long term.